Well, thanks everybody for joining us this afternoon as we continue on our lecture series. Today we have Jeff Cole joining us. Jeff is a second year pharmacy resident at Yale New Haven Hospital and has been gracious enough to help us out in determining, or I guess investigating, the anticoagulation strategies for left ventricular assist device. I think this will be really informative, and I'm really excited to see what Jeff has in store for us. So Jeff, thanks again, and look forward to your presentation.
Cool. Thank you, Dr. Beasley. So I'll go ahead and get started. So hello, everyone. Like you said, I'm Jeff. I'm the current PGY2 cardiology pharmacy resident. And today, the focus of this presentation is going to be on LVAD anticoagulation strategies, current recommendations, and then also some future directions. So no disclosures to report for myself for this presentation. And then a couple of objectives for today. So first, we're going to review the mechanics of left ventricular assist devices, or LVADs. Second, we're going to discuss, why do we actually need anticoagulation in LVADs? And then third, which is I think the highlight of this presentation, is to analyze current anticoagulation strategies and also look at some future directions. So first, just to talk about a quick overview of the LVADs. So I have a diagram here of the HeartMate 3. I'm just pointing out some of the different components of it. So they're labeled nicely on this diagram. So we have an inflow cannula, we have our implantable pump as well, an outflow graft, our external drive line, and we also have our controller, and then the energy source, which are 2 batteries that patients have, as well as they'll also carry backup batteries on them as well. And the parameters that we're looking at for LVADs are speed, power, flow, and pulsatility index, or PI. But just to note that the only setting that can be manually adjusted is the speed. The other values are calculated values. So that's kind of like an overview of the LVAD. And I thought it would also be nice just to kind of go back through the history of LVADs, of where we started compared to where we are now. So one of the first LVADs was the HeartMate 1000 IP. So this LVAD actually had a low thromboembolic complication rate, despite minimal anticoagulation that was used, which I find pretty interesting compared to what we do now for our LVADs, and really starting to give consideration of using this for long-term therapy for our patients with advanced heart failure or advanced HFrEF. So that was the first LVAD that we had. The second one we had was the HeartMate XVE, which, if you look at the console, it was massive compared to the first one, the 1000 IP. So with this one, the main study that looked at this type of LVAD was the rematch trial. So this was our landmark trial for the HeartMate XVE, and also of note, within this trial, there was not routine anticoagulation used. So as we've seen, the components are kind of similar, but then kind of the positioning of them, and also looking at the drive console, this is much bigger compared to what we have for our current LVADs as well. And then we started to get into a little bit more of the durable with the HeartMate 2. So the HeartMate 2, the main study, I have the screenshot from some of the subgroup analyses from this study. It compared the LVAD XVE compared to HeartMate 2, and noticed that the HeartMate 2 had higher survival from disabling stroke or need for device replacement, which is noted here on favoring the continuous flow of the HeartMate 2, and also cardiac arrhythmia and some of the other adverse effects. So bleeding, stroke, and pump thrombosis were not too significantly different between the groups, but overall that higher benefit from survival free of disabling stroke, which was notable. And also within this study, aspirin was used in both arms, but then warfarin was only used in the HeartMate 2 arm only. So kind of painting the picture of where we started with anticoagulation, antiplatelet, and kind of how that's progressing as the years are going on with these new LVADs. And the final one, which is the one that we are currently using in all of our patients, is the HeartMate 3, which was on the diagram at the beginning, one of the first slides that I looked at. So the main trial, which is a screenshot that I have here, was from the Momentum 3 trial. So this compared the HeartMate 2 to the HeartMate 3. And all patients got doses of aspirin between 81 and 325 milligrams a day, and then also warfarin with a goal INR of 2 to 3. And the HeartMate 3 had higher survival free of disabling stroke and decreased risk for pump thrombosis. So we've got like suspected or confirmed pump thrombosis, any stroke, as well as disabling stroke, and also less bleeding, which is notable, which I'll talk about a little bit of common complications that we'll see with LVADs. So another thing to point out is like, why did the HeartMate 3 have, more benefit than the HeartMate 2? There are some differences between actually like the mechanics of the LVAD. So the HeartMate 3 has an artificial pulse. It is a large secondary flow pattern and also a fully magnetic rotor. So overall, those pieces will allow for decreased risk for pump thrombosis. So from starting from the 1000 IP to here we're at the HeartMate 3, much more durable. And then we also have like lower rates of complications and bleeding with the HeartMate 3. So currently, this is just from the Heart Failure 2022 guidelines of, what kind of patients are we thinking about that are indicated for LVADs. So in select patients with advanced HFrEF with NYHA class 4 symptoms deemed to be dependent on either continuous IV inotropes or temporary MCS, durable LVAD implantation is recommended to improve functional status, quality of life, and survival. And this was a class 1 recommendation and had the highest level of evidence with a ranking of A. And oftentimes with these LVADs, we're kind of thinking of the common terms we're using are destination therapy versus bridge therapy. Destination therapy where they're going to be with the LVAD for the rest of their life versus a bridge therapy is, can we use the LVAD for a certain period of time while we're bridging them to eventually get a heart transplant. And then some of the common complications of the LVADs are the pump thrombosis, bleeding in general, but also there's an increased risk of GI bleeding, as well as intracranial hemorrhage. Patients can also have cardiac arrhythmias, stroke, which is kind of like a thrombotic complication, infections, specifically driveline infections, because it's an external driveline. So a lot of our patients will often be on like chronic antibiotic suppressive therapy if they have recurrent infections in their driveline. Also hypertension, right heart failure, and then just general device malfunctions. So these complications are kind of leading into, okay, why do we actually need anticoagulation for our patients with LVADs? Overall, the LVAD is a source of shear stress in foreign material that can lead to platelet activation, which I have shown in this diagram right over here. And then there's also like an interplay between platelet activation and their interaction with the clotting cascade, which is why originally we were looking at antiplatelet and anticoagulation therapy. And the next screenshot I have is kind of showing this interplay between the platelet activation and the clotting cascade. And really what I want to highlight on this is, okay, what have we conventionally used for antiplatelet and anticoagulant therapy? We have aspirin, which is going to act right over here on the platelet activation side. And then we also have warfarin, which is going to act on our intrinsic and intrinsic pathways, the vitamin K dependent factors on the clotting cascade side. So showing that, why we actually need anticoagulation for these patients. And I'm going to get into why we don't always need any more of the antiplatelet therapy. So a thrombus can form from the interaction of blood with the surface of the LVAD. And then there's an interplay between bleeding and thrombotic events in patients with LVADs. So some of there are patient-specific factors with the LVAD and also exogenous factors. So, hypercoagulable state is one example of the patient factors, the type of LVAD that you have, the pulsatility, and then also, what is your anticoagulation regimen? What are your antiplatelet regimen? And, are you compliant or adherent with your medications as well? So our current recommendations are in patients with LVADs, warfarin is the preferred anticoagulant with an INR goal of 2 to 3. Higher INR goals of 2.5 to 3.5 can be considered in patients that have thrombotic complications from their LVAD, such as pump thrombosis or stroke. And actually, aspirin 81 milligram is no longer recommended to be used in combination with warfarin for antiplatelet therapy in patients with LVADs. And this was based off of the ARES HM3 trial. So this was titled Aspirin and Hemocompatibility Events with a Left Ventricular Assist Device and Advanced Heart Failure. And what they wanted to look at this trial was to see if we exclude aspirin as part of the antithrombotic regimen in patients with an LVAD, is it safe and does it also decrease bleeding? So this is a large double-blinded RCT that had around like 580 patients, and patients that had an LVAD that were already on warfarin were randomized to either get aspirin 100 daily or placebo. And their primary outcome was survival free of major non-surgical, which they defined as greater than 14 days after implantation, of the hemocompatibility related adverse effects, which is going to be a common theme in a lot of these trials, abbreviated HRAE. And these include stroke, pump thrombosis, major bleeding, or arterial peripheral thromboembolism at 12 months. So the population within this trial, like, mainly male patients, white, had an Intermax score of 3, 45% of them, and mean age in the high 50s, low 60s. So for the primary outcome, they actually found that it was 74% with no aspirin versus 68% with aspirin, meeting that criteria for non-inferiority, and there was a 6% absolute difference, p-value less than 0.001. And for secondary, there was no aspirin had lower non-surgical bleeding, and then there's no increase in stroke or thrombotic events. So this was, overall, it was a really strong study, at a large sample size of patients, which some of the other studies I'm going to talk about, that's not the case. It was enrolled patients in 9 countries across 51 centers. So it has good external validity and good clinical applicability. What it found was that there is an increase of thromboembolic events and there's a decreased risk for bleeding. So here at Yale, we have stopped routinely prescribing aspirin in patients with LVADs as like a standard of therapy. Not to say that there could be some patients that are on aspirin, maybe for another reason, but it's part of post-implantation, we're not routinely starting low-dose aspirin in these patients. So now we talked about, so we're not really doing aspirin anymore in these patients, and still the standard of therapy is warfarin with that goal INR of 2 to 3. So now we're going to look at some of the future directions. So the main thing we're looking at is DOAC use in LVADs, and so the maintaining INR within therapeutic range is very important for LVADs, and that time in therapeutic range, or TTR, correlates with clinical outcomes. But high TTR is very difficult to achieve. Warfarin has a lot of drug and food interactions. There's some interpatient variability, and then there's also a need for frequent INR checks. So due to these considerations, DOACs have started to be studied in LVAD patients. And then I'm going to talk about 3 studies that have previously looked at apixaban. So first one is the DOAC LVAD study. The DOAC LVAD trial. So this was evaluation of hemocompatibility of the direct oral anticoagulant apixaban in left ventricular assist devices. This was to determine if treatment with apixaban would be feasible and comparable in terms of safety and freedom from those HRAEs compared to warfarin in patients with LVADs. And so all these patients were randomized to receive either apixaban 5 milligrams twice a day versus warfarin, and all patients were required to take low-dose aspirin. And the sample size was relatively small, a sample size of 30. It was noted that there was 16 patients that got apixaban versus 14 patients that got warfarin, for a total of 30 patients. So the primary outcome was composite of death or major HRE, which I mentioned before, followed for 24 weeks or for 6 months. And so for the patient population, mainly male, higher percentage of Black patients, being age of 60, and most of their etiology was non-ischemic cardiomyopathy, and 9 of these patients were for destination therapy. So for the primary outcome, 0 patients in the apixaban group had a major HRE versus 2 patients in the warfarin group. Serious adverse effects were lower in the apixaban group, but not statistically significant. And the most common adverse effects was the driveline infections. And then one patient in the warfarin group developed RV thrombus. So they concluded that apixaban was feasible in patients with an LVAD without those excess and adverse effects, essentially informing future clinical trials looking at the safety and efficacy. But I do want to point out, there are some big limitations within this study. That small sample size that I mentioned is one of the biggest ones, and that's going to be a common theme with these newer DOAC trials. And mainly, they stopped at 16 patients in the Eliquis group. They didn't recruit more than that. Essentially, they wanted to simulate a prior study that had been done a couple years prior that started to look at dabigatran or Pradaxa in LVADs, or I'm sorry, in HVADs, and they actually had to stop that trial early because there was increased risk of pump thrombosis. And in that trial, they only had 16 patients that were in the dabigatran group. So this trial essentially wanted to simulate that and be like, okay, let's get the same numbers to prove that it is feasible for apixaban. But obviously that was in HVADs. This is now looking in LVADs. And for the HVAD study with dabigatran, they were followed for 8.5 months versus compared to this study, they were followed for 24 weeks or 6 months. So that we could have seen more adverse effects if these patients were followed for longer. So it is very good for like looking at feasibility, but just noting that there are some limitations with it. The next one is the DOT HM3 study. Looking to determine the safety and efficacy compared to the HRAE in DOAC of DOACs and HM3 LVADs compared to warfarin. This is a randomized open-labeled study, and for patients that were 3 months post-op who had already tolerated warfarin with no bleeding, were randomized to either get 5 BID of apixaban or continue on warfarin therapy. And the apixaban group was further stratified to aspirin 100 milligrams or no aspirin at all. And while this study had more patients, 45, still not a huge sample size. And it's looking at the same outcomes as the previous study as well. These were all male patients, all white patients, and these patients had higher percentage of ischemic cardiomyopathy. So looking at the primary outcome, it was 86.7% in the apixaban plus the aspirin, 93.7% in just the apixaban alone, and then 85.7% with warfarin plus aspirin. And then there were a couple of patients in each group that did develop a bleed. One patient in the apixaban plus aspirin group that developed a GI bleed. So this was once again kind of confirming, a strategy of switching to warfarin to apixaban is feasible to either bridge transplant or destination therapy, but still noting that larger scale and long-term trials are needed before adoption into clinical practice. And then one of the newest studies actually that recently came out, I think at one of the transplant conferences that happened a couple months ago, was the apixaban trial. They reported their interim analysis. So this is looking at low dose apixaban in the HeartMate 3 LVAD patients to see if the low dose was non-inferior to standard warfarin therapy. And this was a randomized controlled open labeled pilot trial. And patients that were post-op for at least 2 months from a HeartMate 3 and had a TTR of greater than 60% in that 1 month prior to randomization were either randomized to get apixaban 2.5 twice a day or warfarin therapy, but aspirin use was not mandated. So the primary outcome was those HAREs. And once again, similar theme, mainly, elderly white patients, males. Most of them were bridged to transplant, but 84% had 84% TTR pre-randomization, and 68% of these patients within this study did have background aspirin use. So compared to warfarin, it was 14% with apixaban versus 8% with warfarin. It was p-value of 0.7, so it was below the non-inferiority margin of 20%. So these interim results suggested that apixaban 2.5 twice a day could offer an effective balance between bleeding risk and anticoagulation efficacy in HeartMate 3 LVAD patients, but these are mainly preliminary and hypothesis generating. This is also an interim analysis. So as I was reading it, it's like kind of stamped in front that it's interim. So I don't think there would be any changes to the results once the full analysis comes out, but just want to add in that caveat that we want to see the full study as well, and I'd also like love to dig into like the supplement and really get some of the more um, gritty details of what they're doing because I think now that we're looking at okay, a Pixaban 5 twice a day might be efficacious. Now we're like, okay, well, what if we lower the dose even further to 2.5 twice a day, and are we going to have that same efficacy and safety as well? So some of the key takeaways from this presentation, I just want to point out. So LVADs are indicated in patients with advanced HFrEF and dependent on inotropes/temporary MCS. Patients with LVADs are at an increased risk of thrombotic events and will require lifelong anticoagulation therapy. Standard of therapy for LVAD anticoagulation management remains warfarin with a target INR of 2 to 3. And once again, maintaining that TTR with warfarin continues to be a challenge in patients with LVADs. And then DOAC, specifically apixaban, may be safe and efficacious as anticoagulation therapy for LVAD patients. However, more studies are needed to confirm this. So I do think it's an interesting idea and an interesting, future direction. I do think we're going to need more studies with higher sample sizes and really looking at the potential real world applicability before we make that switch to recommending this for our patients. But I do think it is something that is on the future that we might be able to do at some point. But if you had to ask me today, still recommending warfarin with an INR goal of 2 to 3. And with that, I will take any questions that you guys have. I like to put in a nice little cartoon at the end of my presentation. So whoever's charging their Tesla might also be charging their LVAD. So thank you guys so much for listening to my presentation, and I'll take any questions that you guys have.
Thanks, Jeff. That was really, really good. Great job. Any questions from the listening group? I was going to ask, is there, and maybe you did show something, but what about INR targeting or using warfarin but targeting a lower INR for patients that might have increased bleeding risk? Did you come across any data to support that practice at all, or what are your thoughts on
Yeah,
that?
yeah. So I was in this trial, the DOAC LVAD trial. So their protocol in this study was actually to target an INR of 2 to 2.5. They did report, what percentage of patients were 2 to 2.5 versus 2 to 3. So they did kind of parse those out. But for this study, they did target a lower INR. But the two other studies that used warfarin, this one and the apixaban, they did have a target INR of 2 to 3. So I think it is reasonable if, like, let's say some patient has maybe a huge GI bleed or like a recurrent GI bleed with an LVAD, and they haven't had a thrombotic complication. I think it could be reasonable to trial out a lower INR goal, but I think it was only this study that really had compared the lower goal, or like used the lower goal of 2.5 like within their actual protocol that I saw.
Jeff, this was a wonderful talk. I just have a question that they're talking about HeartMate Mini when it comes out and some different element. This is specifically just for HeartMate 3 because this is what we're studying. And so all of this is going to have to be repeated with future.
Yes, exactly. So if the trend continues as what we've seen historically, like I think each step of the way we're looking for that. Can we improve these VADs as much as possible? And yeah, so if we get a totally new device, then these studies would have to be repeated. But for our patients that will still be in the population, even after those new devices are implemented, we could still maybe apply this data to those patients as it's going to be the majority of the population. I think now, like most of our patients that get admitted have a HeartMate 3, but we will have an occasional HeartMate 2 as well. So it might be the same thing as we start to phase out the older ones with like the newer generations that are coming out.
Thank you. And then one more question. Is there any role for PPI? I know like hemocompatibility, we're talking about strokes and GI bleeds and not necessarily, or thrombosis. And so it's just like a random like hosh-posh of everything related to hematology issues. But is there any role for GI prevention with PPIs with patients that are chronically on anticoagulants?
Yeah, I mean, I know in terms of like, let's say the non-LVAD population, like there is a role for patients that might be on that are on DAPT, or maybe they're on triple therapy for a certain amount of time. You know, the guidelines do recommend of like starting patients prophylactically on a PPI. You know, I'm not 100% sure if that's like a routine practice for our LVAD patients. Even though there is a higher, like, you know, warfarin obviously is an anticoagulant, higher risk for bleed, and then the LVAD itself has a higher risk for GI bleed. Um, so I'm not 100% sure about the data behind it. You know, I don't know if I'm necessarily recommending it, but I wouldn't like say not to do it if like if we're like rounding with the team and they want to start a PPI in a patient that has an LVAD and is on warfarin.
I think
So
it all depends on the, you know, the etiology of the bleed, right? So like a lot, as you think in your slide that you had with most, you know, common side effects, you know, the AV malformations, which may or may not have been there. I guess it wasn't there, but you know, so like, you know, a lot of the GI bleedings due to these AVMs that form, and which I don't necessarily think you're going to get any benefit for putting somebody on a PPI in that case. And you know, things, Omar, that are used instead in some cases are things that kind of reduce splanchnic blood flow, like octreotide. Um, you know, would be something that you might see in patients that have recurrent GI bleeds because of that specific etiology of GI bleed. But I think it all just depends on what the underlying pathophysiology is.
Makes sense. Thank you so much.
Okay, and then in the chat here, so the Magentum 1 study, a very small study with 15 patients, showed, oh, this is great. This is going to my question. So looked at lower INR goals of 1.5 to 1.9 and showed feasibility for lower INR goals, although further studies needed. So thanks, Mabel, for sharing that. That was kind of what I was wondering, if there was any data to kind of look at INR goals of 1.5 and above. So a little bit of data with 15 people.
And just a quick question to clarify. So here at Yale, our protocol is to do warfarin with an INR goal of 2 to 3. Is that correct? Without
yes.
aspirin?
Yes.
Okay. Has there ever been any talk of transitioning to, you know, like the single INR like we do for mechanical valves, like 2.5 or 3? I don't know if that would be of any, you know, benefit for this population, but just curious.
That's a good question. I don't
I don't think
believe
so.
so.
Mhm.
I would even still recommend, even with our mechanical, like with our mechanical valves, or like, I still think a range is much better. Much, because like it's already hard to keep it in within that range versus like targeting like a specific number. So I don't know if we would ever go to that, but I would think like keeping that goal of 2 to 3. That's what I would assume that we would continue to do.
One more question, if that's okay, Jeff. A couple of years ago, they were talking about thalidomide and using it to prevent AVMs and LVADs. Has that ever panned out? This was like a couple of years ago when I was doing some heart failure stuff. Has that ever panned out for LVADs using thalidomide?
Did you say thalidomide?
Thalidomide, yeah, they were using it as an anti-neogenesis type of thing to prevent AVMs. Uh,
Um, I will, to be totally honest, I have no idea.
okay, yeah,
I will default to
I always
Mabel,
assumed that it
who's also in
never
here.
panned out.
She might know, but I'm not aware of any of that.
Hi, this is Ada. I'm one of the fellows at Utah. I think there's only like a small, like a handful of studies that are small, and I think single centers that kind of bore out the thalidomide usage. I don't think there's any like large studies or multi-center studies to kind of support that, but that's kind of the case with all of these adjunct therapies for LVAD, like bleeding complications like digoxin and thalidomide and bevacizumab. They're all kind of like small center, small trial, like small data, usually like retrospective.
Can you guys hear me?
Yeah, now we do.
Okay, sorry. I think I've been having a difficult time unmuting. Agree. There's not a formalized guideline for GI associated bleeds or AVMs. associated with LVAD and anticoagulation. Thalidomide has been previously used, but I believe those studies were also pretty much case series at best. It's probably, I would say, third line treatment, if anything, but there's very little data in terms of like prospective randomized studies, unfortunately. There's things like omega-3 fatty acids that have been studied, octreotide long-acting release has been studied, doxycycline has been studied, ACE inhibitors and ARBs have been postulated to be beneficial in prevention. So there's a lot of different things that have been studied, but nothing has really given us great data from a prospective randomized controlled trial standpoint. Oh, and there was the other previous question about changing INR goals from 2 to 3 or to just a flat number of 2.5. I think that kind of hits the updated guidelines with the valvular heart disease guidelines and anticoagulation from that standpoint. They do recommend, instead of targeting 2 to 3 or 2.5 to 3.5, to just target 2 or 2.5, just so you're not going at the lower ends of the spectrums. But I think in clinical practice, most of the time, we're still seeing that the majority of folks actually still prefer to have the ranges as opposed to targeting one number. And I think that's probably where our team also falls as well.
Thank you, Mabel. So thanks again, Jeff. Fantastic talk, and thanks for everybody for joining and all the great questions. We're back next week with a talk on frailty and heart failure, which should be really interesting. I'm excited to see what that talk's going to be about. So thanks, everybody, and see you next week.
Thank you.